All right, here's lesson 26. It starts the cases F unit in our EMT course. We're going to talk about OB, GYN in this lesson, then we'll do one on newlyborns. This lesson is kind of long, online, and then we're going to do some lab session where we really focus on some simulated deliveries and then how to manage that critically ill newborn at the BLS level. But this presentation is about OB/GYN problems. So we'll talk about gynecological stuff as well as problems in pregnancy and then some childbirth. There's a great deal of information in both your textbook and in the resources document. There's some anatomy you need to understand and know and be clear on. What are the ovaries? What are fallopian tubes? Uterus, the cervix, what is the perineum? What happens when there's perineal tears? And then the vagina also is part of the anatomy stuff we're talking about here. And then conditions where you have an ectopic pregnancy, which can cause life-threatening bleeding if it ruptures. Ovarian cysts are very common, a very common cause of abdominal pain in women of childbearing age. And then what is a spontaneous abortion or miscarriage? Also know the terms last menstrual period, LMP, gestation, estimated delivery date, and know the difference between dilation and effacement and what we're talking about there. And then understand Braxton Hicks contractions, understand how to time contractions, what is crowning, and then the vertex and breech presentations are also important terms. So there's a lot of terms here that you don't run into anywhere else in your medical assessment and treatment. And so the terminology is a big piece of this lesson. And there's good explanation, again, in your textbook on all these things. From a gynecological call perspective, you can have vag bleeding. You can have PID, which is pelvic inflammatory disease, ovarian cysts, or an ectopic. And we'll talk about how to deal with vaginal bleeding. The PID patient presents in a great deal of discomfort. And in almost all these cases, there isn't anything from a BLS perspective that can be done. Very little from an ALS perspective. CVO, check for signs of shock, managed shock, would be a hypovolemic shock. And then these are also parts of abdominal pain, which we touched on way back in the GI lesson where we talked about abdominal pain, and we needed to add in a couple of OB/GYN sorts of things in those cases. Vaginal bleeding is internal bleeding that is leaking out. And so direct pressure is obviously silly. So we're going to collect the bleeding in absorbent pads. In many cases, the female patient will have an absorbent pad already in place. And if not, or we need to supplement that, then we just use regular gauze and such. It would be reasonable to collect everything that you've used to soak up any vaginal bleeding because it is legitimate for bleeding to be quantified in terms of number of pads soaked per hour. And clearly this can lead to hypovolemic shock. Vag bleeding can be very serious in terms of volume, and it can be enough blood loss to lead to hypovolemic shock. In the pregnant patient with vag bleeding, we need to differentiate between a placental abruption, an abruptoplacenta, and placenta previa. Placental abruption is painful and has vag bleeding in third trimester. Painful vaginal bleeding is a placental abruption. That means the placenta has torn away from the uterine wall, which means that the baby is no longer getting any blood supply or nourishment, and that is clearly an emergency for the baby. An immediate C-section is the answer there. Placental abruption is probably a significant cause of spontaneous abortion, of miscarriage as well. Placenta previa is painless, but still vag bleeding, and that is where the placenta has attached inappropriately low. As the cervix starts to open up, then the bleeding becomes external. Pregnant patients can also have gestational diabetes. This is diabetes that goes away once the pregnancy is over, but it's diabetes nonetheless. And so there are hypoglycemia issues to be dealt with. Many times I think the patient will know about that. If they have any prenatal care, this is screened for. I need to talk about supine hypotensive syndrome. The situation there is that you have a large, heavy object, the baby, in the gravid uterus, the uterus that is getting larger, and that uterus is pushing down on the inferior vena cava. So the return hose to the heart is being compressed. So it's being compressed by the baby. If we can simply turn the patient to her side, we can get that large weight off of the vena cava, and we can return blood flow to normal. Remember that your heart can only pump out what it gets in, and so if there's reduced blood flow coming into the heart, then cardiac output has got to go down. We want to talk about preeclampsia and eclampsia. So again, painful third trimester bleeding, that's an abruption, abrupto placenta. Non-painful third trimester bleeding is placenta previa. The placenta has attached inappropriately low. And then miscarriage is the usual layperson terminology for a spontaneous abortion. That means that for whatever reason, the pregnancy is terminating itself on its own. And this is, I can tell you, unfortunately, from personal experience, that this is a very emotional time. And I have yet to find anything that I can say as a care provider to the patient or family that really matters. I simply try to convey that I really do feel for where they're at, and this sucks for everybody, but this is emotional. From a medical perspective, yes, there can be significant bleeding. Usually it's not catastrophic, but a termination of a pregnancy, an unwanted termination of that pregnancy is emotionally devastating to everybody involved. Preeclampsia, usually found in prenatal care. Only about 5% of pregnancies have this. That number is, kind of an average. You'll see sources lower and sources higher. Preeclampsia involves hypertension, several measurements over a period of time of 140/90 or higher. And again, this should be caught in prenatal care. I think in many cases, we are encountering patients who have had little or inconsistent or no prenatal care, and so maybe we're going to detect this, but usually the patient with prenatal care, this is screened for and they know about it. Sorry. There's a whole bunch of other stuff. There's some urine measurements and things that we're not going to be able to see, but in the field we would see a patient who is potentially edematous, lots of swelling, may have some vision disturbances, may have some headaches, this may progress to seizures. When preeclampsia patients have a seizure, it is no longer preeclampsia, it's now eclampsia. The issue is the body is uncomfortable with the baby, is seeing the baby as an invading force, and the patient is basically toxic due to the pregnancy. Once the pregnancy is resolved, then in almost all cases the eclampsia symptoms resolve. So seizures in the pregnant patient are assumed to be eclampsia. Seizures in a patient who is postpartum, has delivered in the recent hours, days, weeks, it's still considered eclampsia. That's not intuitive. That is something that didn't make sense to me when I first heard about it. But a patient who is pregnant or was recently pregnant who is seizing is presumed to have eclamptic seizures. And then the difficulty comes in a patient with known seizure history who then gets pregnant. Which are we treating? Are we treating the epilepsy or are we treating the eclampsia when they have a seizure? And from a BLS perspective, it's all the same. From an ALS perspective, it's presumed to be eclampsia in almost everybody's system, everybody's protocol. And why is it a big deal to the medics? Well, the medics give different medications. A patient who is pregnant who is seizing does not get the usual Valium, Versed, a benzo. So just for your own background information, the medics care because it is different medication treatment they're going to use. But the treatment for seizures is the same whether the patient's pregnant or not. And at the BLS level, that is supportive. Don't let them hurt themselves. Don't restrain them. And manage CVO as best you can. Once the seizure stops, you have a better chance at airway management than during the seizure, but seizures are seizures. As far as childbirth goes, and you can read in your book about this and read in the resource materials, the stages of labor are something that are in the National EMS education standards, and everybody thinks you should know. And so the first stage of labor is from the beginning of contractions until full dilation. And so how would you be able to tell if the patient's cervix is fully dilated in the field? Well, you wouldn't. So you really don't have any way to know when they've transitioned from the first stage of labor into the second. The second is from full dilation till delivery, and the third one is from delivery until the placenta delivers. You can tell when those have happened, but how you know if we're in the second stage of labor now in the field is impossible. So it's a rather trivial, esoteric sort of point, but you can read about that, and you may well face questions on that in a multiple choice exam that you might take at the registry or something. Dilation and effacement, that's talking about the cervix. The cervix is normally closed as it starts to open or dilate as birth becomes more imminent. As the dilation begins, then a mucus plug will be released, and they can measure in the hospital. Nursing staff as well as physicians obviously are trained to do a digital exam of the cervix and estimate how dilated, how large the opening has become. And then effacement involves that you understand that the cervix is a tube. And so the cervix opens up, gets larger, and it also gets shorter and thinner. And the effacement is the thinning of that. And again, there's materials in your textbook and the resources on that. Braxton Hicks contractions, really hard to tell whether those are Braxton Hicks or whether they're real contractions. Braxton Hicks contractions are not related to an imminent delivery. First-time moms have a hard time with that. And you can, again, read about that further. But we wanted you to at least have that in a list of things for you to be aware of. When we're talking about contractions, we're trying to decide how close we are to an imminent delivery. And so that means how regular are the contractions, how frequently are they occurring, and are they strong? So a strong, regular contraction that occurs more and more frequently means that delivery is becoming more and more imminent. And we time contractions by the timing from the start of one until the start of the next. And to me, that's not intuitive. When I was first learning this stuff, I thought if someone said that contractions are 2 minutes apart, that meant that it was 2 minutes from the time one ended until the next one began. That's not the case. Contractions are measured from the start of one to the start of the next one, because it's a little harder it's a little more vague to determine when a contraction has ended than when it starts. So it's start to start on that, and you should know that. Did your patient's water break is kind of the slang. So the rupture of the membranes and the release of the amniotic fluid is when the water breaks, so to speak. And that does not necessarily indicate that birth is absolutely imminent. In many cases, well, in some cases, it can be many hours between the time of the rupture of membranes and actual delivery. But it's yet another thing for you to know and be able to talk about. There's a whole bunch of terms here, as I said earlier, that you really only run into in this setting. And so there's specific terminology, and we ought to be able to converse in this language. And part of that is gravida, para, and aborta. So a patient who, gravida means the number of pregnancies. Para means the number of live births. And aborta means the number of aborted pregnancies that's occurred. So a patient that's G3P2A1 is pregnant for the third time, G3, gravida 3, and they're para 2, they've delivered twice, and then they had one abortion. Just as an example. And again, read about that in your book and get right with that terminology. Sorry. So what we care about in the field is imminent delivery. If I got to deliver this baby right here, right now, or can we start transport and hopefully make it to the hospital? We would prefer to deliver a baby sitting still. So if a birth begins to happen during transport, we're going to want to pull over to the safest place we can get to as soon as we can. It's difficult enough to move around in the back of the ambulance without having to do anything. It's difficult enough to control a brand new, slick, slimy infant that you may have to resuscitate urgently when you're not moving. And to try to do both of those things, be moving and also deliver and resuscitate a newly born, is just insane. So we're going to try to pull over as soon as we can. We would like to not even start transport if the birth's going to happen real soon. And so it's a judgment call. Can I make it to the hospital safely, or are we going to need to do this right here? How do you know if birth is imminent? Strong, regular, closely spaced, frequent contractions. The patient has an urge to push or an urge to move their bowels. There's pressure down there, and it feels like they need to have a bowel movement. And then is there crowning? Is there a presenting part? When you look, can you see a head or an arm or a leg or something like that? That's called the presentation. And the presenting part is incredibly important. A vertex presentation, head first, face down. That's the normal, what we're looking for. Head first, face down. And we can deliver those in the field. Anything that's not vertex is breech. So foot first, butt first, arm first. Anything that's not head first, face down is breech. Breech presentations are non-field deliveries. We do not want that baby to be born and get hung up, because if the head doesn't come out first, everything else is not as wide. The head is the widest part of the baby. So we can get the widest part out first, then the rest of the baby can come out pretty smoothly in many cases. But if the more narrow parts come out first, then the head can get stuck, and we're not equipped in a field setting to deal with that. Most breaches are going to be C-sections anyway, so not going to be vaginal births. They're going to be done surgically with a cesarean section. The other thing we want to talk about is umbilical cords. What's its purpose? What's it do? When and where and why and how do you cut it? Because the cord becomes a central focus in many cases. So the purpose of the umbilical cord is to circulate oxygen, glucose, nutrients. It is so mom can support the circulation of baby. It's very interesting, very unique shape, has several vessels in it. Not important at the BLS level, that you know that, but the cord is it's an amazing thing, as is the placenta. The cord attaches to the placenta and then to the baby. The placenta acts more or less as an adapter between the mom's circulation and the baby. So what do you care about cords? Well, when would you cut the cord? Why would you cut the cord? Well, you need to not worry about cutting the cord unless you need to separate mom and baby. If mom or baby needs to be resuscitated, then you need to separate them. But you don't need to worry with separating them until it's time for you to work on one or the other. You can take your time. It's not imperative that you cut the cord as soon as the baby's out. Where do you cut it? Well, you need to make sure you leave it plenty long. And so 4 to 6 inches from the baby is totally appropriate. I'm going to overshoot. I'm going to have people at the hospital making fun of me because I left the cord too long, and that's fine. They can always modify it. They can recut it. They can shorten it. They can do whatever they want with it. ALS providers may end up using it as a means of circulatory access for the critically ill newborn. They can also adjust it. I just don't want to cut it too close because I can't, ever go back. How do you cut it? Well, you clamp it in 2 places with your closest clamp, no closer than 4 inches from the baby, and your next one an inch or 2 away from that. You clamp it in 2 places and you cut with a scalpel between the clamps. The scalpel and the clamps come in the OB kit. Complications, well, you can have shoulder dystocia. That is usually big baby, small mom. And so head comes out, but then shoulder gets stuck. And you can read about that and see that in the resources as well as your textbook. Meconium, which is fecal matter, it's stool, it's bowel movement, its baby had a bowel movement while still in the uterus. That indicates the baby was stressed. That is an icky, sticky substance that can get on the baby and can get in the baby's airway, but doesn't always. Just because it's on the baby's head or face doesn't mean it's also in their airway. If it's in their airway, it's difficult to suction. It can cause them some respiratory distress. So if your baby's having trouble breathing and there's meconium in the airway, then we're going to deal with it. Otherwise, we're not going to mess with it too much. But you should recognize that the presence of meconium means that the baby is stressed or was stressed at one point. And then uterine rupture can occur, and that sometimes goes along with that shoulder dystocia. A uterine rupture means just what it sounds like. The uterus has split open, for lack of a more tactful term. Why would a uterus rupture? Well, the number one reason would be that there was a prior cesarean section. They had a C-section. They had a surgical delivery of the baby, which meant that there was an incision made in the uterus and then it was stitched up. And so you have a surgical scar. And then with successive deliveries, if they were, to be some pushing and some stress on that scar, it could open up. And then without that, if there's excessive force being used on pushing, so mom is really struggling, baby's shoulders are stuck, and then that uterus can rupture. Could also be from a traumatic situation. Uterine rupture would mean that during a contraction, suddenly the uterus is, you can palpate the uterus, you can feel the contraction externally, and suddenly there's no more contraction, and the uterus has ruptured, which means baby is no longer contained there and is free floating in the belly, and that's a huge problem. Then postpartum hemorrhage, that means after the delivery has happened and after the placenta has delivered, the patient continues to bleed. And a little bit of bleeding is not a big deal, but sometimes it's pretty significant bleeding. And how do we manage postpartum hemorrhage? So, postpartum bleeds. Once the placenta decides to deliver, and placentas deliver whenever they want to. Sometimes it's 2 or 3 minutes after the baby, sometimes it's 20 minutes after the baby. Placentas do what placentas want to do. So when the placenta decides to deliver, it will detach from the uterine wall, where it has been attached as an adapter between mom and baby. And during that detachment, there will be a little gush of blood. There will be a little bit of blood released. I don't know how to quantify it other than to say a small gush. And then that should be it. And then the placenta should deliver and there shouldn't be any more bleeding. Maybe a little dab or so or a trickle, but there shouldn't be a flow of blood. If there is, that's postpartum hemorrhage. That's a big, hairy deal. And so the first way to deal with that at the BLS level is to do fundal massage. And we will show you and let you practice as best we can in the lab setting fundal massage. But basically you take your hands and you massage that uterus and try to get it to contract and go back to its normal size. And that should stop the bleeding. So fundal massage is very definitely a BLS skill. And even if you're the partner of an ALS provider or you're in the presence of ALS care, that's the first step, is ALS directs fundal massage while they get vascular access and prepare to give a medication to stop that. Multiple births are typically known. It's possible that patients don't even know they're pregnant with one baby, although that seems hard to believe. There's multiple stories out there of real-life events where the patient didn't even know they were pregnant at all. And so I guess it's possible that they wouldn't know that they're having twins or triplets. But in most cases, with any reasonable prenatal care, multiples are known. So why do you care? Well, a second baby, the second baby out, or second, third, fourth, fifth, the multiples are more likely to be complicated. That second baby out's more likely to be breech. He's more likely to be smaller. He's more likely to need for you to intervene. He's more likely to be in trouble and need resuscitation. You need more than one OB kit because you don't have enough clamps and placenta bags and all that sort of thing. And the field OB kits are kind of silly anyway in terms of the PPE and the stuff that's in there. But the clamps are important, and scalpel, which you wouldn't have access to anywhere else on your ambulance or fire truck. And so you're going to need more OB kits, and just be ready to do more things to the second, third, and successive babies that come out. So trying to wrap this up, because there's a lot of information in the resources that you'll need to spend a lot of time on, and you'll need to really access your textbook on this stuff. If you have been marginally using your textbook prior to this, you really need to dig into it on the OBGYN stuff. A lot of terms to know, terms that are different that aren't used anywhere else. As with everything, managed CVO, and in this case, whereas with a lot of the altered mental status patients, it was really V and O that were the issue that we had done just prior to this. But now you're back into circulation, hypovolemic shock being a big deal. Be aware of obstructive shock from supine hypotensive syndrome, where you have the patient supine, and that large gravid uterus is pushing on their vena cava, reducing blood flow, blood return to the heart. You can simply move them to the side. So it is obstructive shock, but you can manage this by just positioning your patient. If you need your patient on a backboard, fine, put them on a backboard, but don't leave them flat. Tilt the backboard to the side with your patient restrained to it. You need to figure out if you're going to deliver this baby right now, or if you have a chance to make it to the hospital. Make a good judgment there. You do that based on strength, regularity, and frequency of contractions, as well as is there crowning. And then your whole management of delivery is based on that presenting part. If it is an abnormal presentation, in other words, not head first, face down, not vertex, if it is a breech presentation, then those need to be transported. And we'll show you in lab, and you can see in your book and some of the videos, what positions you can get your patient in to safely transport them on the move and yet use gravity to your advantage. But basically, delivery, you support delivery. Ladies been having babies for hundreds of years without EMTs and paramedics around. Support the delivery. Many of these go just fine. Sometimes the cord's wrapped around the neck. Sometimes the baby needs to be resuscitated. And then we'll talk about in lab and let you practice appropriate care of the umbilical cord. And we just want to caution you again not to be in a big hurry to cut the cord. The cord can stay connected for a long time, but you need to be ready to cut the cord if you need to separate mom and baby. So I kind of went through this fast. There's a whole bunch of material, and this one will deserve some attention on your part. And we do it in Lab 12, which is the last of our required labs. And we'll practice this quite a bit. So we'll see you in lab.